So, thank you, KSOS and Laila Madam, for the opportunity. The preterm babies and the premature birth and low birth weight babies are surviving at a higher rate because of improvement in the NICU services globally. So, in India, around 3.5 million children are born preterm every year, and it accounts for 30% of ROP in India. It's a very huge number. That is the importance of this topic. Now, there are some special ocular features for preterm babies. They appear as having pseudoproptosis due to shallow orbit. The axial length will be small, as well as the size of the cornea is small. Power of cornea and lens will be more. And studies have shown that there will be increase in the cup disc ratio of preterm babies, as well as AV ratio is reduced. So when you consider a preterm baby, the first thing to be ruled out is ROP. You know, as early as 16 weeks of gestation, the retinal vasculature starts developing from the mesenchyme, protruding from the optic disc, and it will be completed nasally by 36 weeks of gestation and by temporally by 40 weeks of gestation. So you all know how to screen this ROP, the various zones and the stages of ROP. I'm not going to the details of these ROP stages and all. And this aggressive ROP should be treated as early as possible, very aggressively. And the gold standard treatment of ROP is laser treatment. And also you can use this anti-VEGF. Now, who needs this ophthalmic screening is gestational age of less than 34 weeks or birth weight of less than 2000 gram. And even larger babies with the high risk factors like oxygen support, sepsis and cardiopulmonary problems, as well as blood transfusion, also need a screening. And as per the pediatrician's discretion, you do ophthalmic screening. So the first examination should be 31 weeks of post-menstrual age or 4 weeks after birth, whichever is earlier, and repeat it weekly or bi-weekly until the retina is fully vascularized as per the guidelines. But always the documentation is very critical. And this is a case of a baby with a gestational age of 34 weeks and birth weight of 2.2 kilogram with a respiratory distress. So we did a screening at 38 weeks. And normal vascularization was in zone 3 in both eyes. But she came 2 weeks back at the age of 6 months. There is no refractive error, no strabismus. She is perfectly normal with a normal visual development. On the other hand, this baby, he had a birth weight of 1.2 kilogram and a gestational age of 34 plus 2 days. And there was no ROP, fully mature retina at 40 weeks. But at the age of 3 years, he came with an alternate exotropia with a V pattern. So why you follow up this patient is a higher risk of visual impairment in preterm babies because of immature retina, optic nerve and brain, and ocular morbidity is lifelong, and they need a structured ophthalmic follow-up, and ROP is a cause of preventable blindness. So what do you look for is the child developing normally? Does the child seem to have normal vision? And does the retina looks normal or healthy? Is there any significant refractive error? Is there any strabismus or nystagmus? Are there any other eye problems like cataract or glaucoma? So what routine workup to be done are visual acuity assessment, axial length measurement, refraction under cycloplegia, dilated fundus examination, and look for ocular alignment and eye movements and measure the intraocular pressure. So as the previous speaker told about the visual development milestones, you have to observe whether the milestones are normal or not, as seen in this picture. So the follow-up depends on whether the preterm baby had ROP, whether it is treated with laser or it was a mild ROP, not treated with a laser treatment. So you can see that in this chart, if there is no ROP, there is a low risk of myopia, and the timing of first examination should be at least at 2 years of age and then annually thereafter. If there is ROP but no laser treatment was needed, then there is a moderate risk of myopia, astigmatism and strabismus, and the timing of first examination should be at least at 1 year of age and then annually thereafter. If there is ROP treated with laser, then comes the high risk of high myopia, astigmatism, strabismus, CVA and anisometropia. So at 3 months of age, you have to see the patient, and every 3 to 4 years till 2 years of age, and after that every 6 months till 6 years of age, and annually thereafter. So this graph shows that there is a low risk of myopia if there is no ROP. In mild ROP, you get a moderate risk, and high risk when there is ROP treated with the laser. So studies have shown that low birth weight interrupts with the emmetropization and increases the prevalence of refractive error. So preterm children are reported to have increased incidence of visual impairment because of perinatal lesions in the brain. So we have done a study on association of refractive status with birth weight and gestational age, a comparative study with term and preterm, and it was shown that there is a significant correlation between birth weight and refractive status, and the incidence of myopia was found to be inversely proportional to the birth weight, and anisometropia was seen more in preterm with statistical significance. So you have to rule out amblyopia as a result of anisometropia, astigmatism following ROP treatment, and you have to manage it accordingly. And strabismus is less common than refractive error in preterm babies, but patients with cerebral palsy it is more common. The degree of misalignment can vary over time. So making the decision whether and when to operate are more difficult than in a children born at term. So CVA should be suspected if parents report that their child does not seem to see normally in the absence of any other obvious ocular disease. You have to rule out cataract and glaucoma following treatment for ROP. Now, in nutshell, the long-term sequelae are myopia, astigmatism, strabismus, amblyopia, nystagmus, CVA, and late retinal detachment. So this baby, 28-week preterm, by screen for ROP detected at 5 weeks, and timely laser was given. Now, at the age of 5-year-old, she is wearing glasses and going to school as a normal baby. So that emphasizes the importance of early detection. But on the other hand, this girl lost her vision in the right eye because of stage 5 ROP, but in the left eye, she maintained the vision of 660 after vitrectomy for stage 4 ROP and after cataract surgery. So you have to counsel and educate the parents about importance of follow-up, highlight the risk of visual impairment, and send follow-up reminders and return follow-up cards. And reviews should be linked with the immunization days, and encourage compliance with spectacles and amblyopia therapy, and reassure them that about preventability with the timely care. So there are 3 major programs in India: RBSK, NPCB, visual impairment, and HM to treat this, to manage this childhood blindness. So to conclude, preterm infants are high risk of eye problems, and ROP is eye threatening, but it is preventable. A structured screening and follow-up is essential even after the completion of ROP treatment. So early detection will better vision, better life. Children who are irreversibly visually impaired or blind should be referred to vision rehabilitation at the earliest. Thank you for your patient hearing.